Hello and welcome back to the deep dive. It is wonderful to have you with us again. Today, my friends, we are not just scratching the surface. We are opening up the bonnet, or the hood, as they say, of the most vital machine we possess. We are talking about the human heart, but we are not discussing exercise or diet or, how to run a marathon today. No, no. We are looking at the crisis moments. We are talking about when the heart is practically under siege, either from bacteria or, quite ironically, from the body's own immune system.
That is absolutely right. It is a very, very serious discussion we are having today. We're doing a deep dive specifically into the empirical treatment protocols for cardiovascular syndromes. And for you, the listener, I want to emphasize that word empirical. It is the key to everything we will discuss today.
Empirical, so treating based on observation rather than complete proof.
Precisely. It means we are acting before we have the full picture in our hands. We are making high-stakes decisions, literally life and death decisions based on probability, experience, and these very specific guidelines we have on pages 15 to 18 of our source stack.
And the stakes could not be higher, isn't it? We are looking at conditions like infective endocarditis, myocarditis, pericarditis, and rheumatic fever. What struck me, reading through this properly, is that the treatment for one could actually be dangerous if you mistake it for the other. It is like a high wire act.
Absolutely. That is the crux of the matter, you see. If you treat myocarditis like endocarditis, you're pumping a patient full of, frankly, toxic drugs they do not need.
Yeah.
And if you treat endocarditis like myocarditis, meaning you just rest and wait well, the patient will likely die from sepsis.
So there is no room for error.
Very little. So the mission for this deep dive is to help you, the listener, understand exactly how doctors navigate this minefield. We are going to decode the logic, the specific dosages, which are quite heavy, I might add, and the why behind every single decision.
So let us start with that word empirical. In my layman's understanding, it feels a bit like an educated guess. You suspect an infection, so you start firing your weapons before you actually see the enemy. Is that a fair assessment?
It is a fair assessment, yes. Basically, in an ideal world, we practice what is called targeted therapy. You take a blood sample, you send it to the lab, you grow the bacteria, you see exactly what bug it is, say Staphylococcus, aureus, and then you see exactly which antibiotic kills it.
The sniper shot.
The sniper shot. Precise, clean. But that takes time. Bacterial cultures can take 24, 48, sometimes even 72 hours. Now, with the heart, specifically with infective endocarditis, you simply do not have that luxury. The valves are being, eaten away by the minute. You cannot just say, let us wait until Monday for the lab report. So empirical therapy is the carpet bombing you do while waiting for the sniper coordinates.
A carpet bombing. That paints quite a vivid picture. And the guidelines mention a very specific concept here called synergism. I found this fascinating. Usually in the corporate world, we use synergy as buzzword, like our teams have synergy, but here it is a matter of strict biochemistry. No.
It is, and it is critical to understand this, to understand the prescriptions we are about to discuss. With heart valve infections, the bacteria create something called a vegetation. Think of it as a fortress. A clump of bacteria, platelets and fibrin. It is very hard to penetrate this biofilm.
Like a shield.
A biological shield, exactly. If you use just one antibiotic, say penicillin, it attacks the cell wall of the bacteria. It weakens the fortress walls. But if you add a second drug, like gentamicin, which works inside the cell on the ribosomes, you get a synergistic effect.
Ah, okay.
The penicillin breaks down the door, and the gentamicin rushes in to destroy the machinery inside. So 1 + 1 does not equal 2 here. It equals 3 or maybe 5. It is a multiplier effect.
So it is a proper tag team attack. One opens the breach, the other finishes the job.
Precisely. And that is why you will see combination therapy throughout these guidelines. It is not just about throwing more drugs at the patient. It is about the specific interaction of the drugs to get that kill shot.
Okay, so let us get into the thick of it. Section 1. Infective endocarditis, or i.e. the bacterial siege of the heart valves. The guidelines break this down into scenarios, which I found very logical. Let's start with scenario A, uncomplicated native valve.
Right. So native valve simply means the patient has their own God-given heart valve. They haven't had a replacement surgery or anything artificial put in. This is the most common presentation. A patient comes in, high fever, maybe a new heart murmur, shaking shells. You suspect IE immediately.
And the rule is, start therapy immediately, do not pass go.
Generally, yes. While the blood cultures are pending, you start the medicines.
So what is the gold standard here? What is the cocktail we are giving?
The first-line treatment is a classic combination. For the main attacker...
As the one breaking down the wall, as you said.
Exactly. For that, we use penicillin G, and the dose is massive. 4 million units, given intravenously or IV every 4 hours.
Wait, 4 million units every 4 hours. That sounds like an astronomical amount.
It is a very high dose. You see, penicillin gets cleared from the body very fast, and we need to maintain a constant high level in the blood to penetrate that vegetation we talked about. Penicillin G is an old drug, yes, but for Streptococcus, which are the usual suspects here, it is still the king.
Okay.
Now, if you do not have penicillin G, or for some reason prefer it, you could use ampicillin, which is 2 grams of 40 every 4 hours. They're essentially interchangeable in this context.
But penicillin alone isn't enough, right? Because of the synergy you mentioned?
Correct. We need the kicker, the second member of the tag team. We add gentamicin. The dose is 1 milligram per kilogram of body weight, given either IV or IM intramuscular every 8 hours.
So if you have a 60-kilogram patient, that is 60 milligrams every 8 hours.
Correct.
Now, I noticed a very specific instruction about the duration of the gentamicin. The penicillin might go on for weeks, but the text says gentamicin is for the first 2 weeks only. Why stop? Why not continue it for the full course?
That is a crucial nuance, and I'm glad you spotted it. Gentamicin is an aminoglycoside. It is a very potent killer, but it has a dark side. It is nephrotoxic, meaning it damages the kidneys, and it is also ototoxic. It can damage hearing and balance.
I see.
So we only need it for that initial synergistic burst to clear the high bacterial load and, sterilize the vegetation. Once we have knocked the enemy down, we stop the gentamicin to save the kidneys, and we let the penicillin finish the job safely.
I see. It is a trade-off. You need to kill the bug without killing the kidneys.
Exactly. It is a tightrope walk. Medicine is always about benefit versus risk. Always.
Now, what if the patient is allergic to penicillin? Or what if we suspect a bug that penicillin just cannot kill? The guidelines list an alternative treatment.
Yes, the plan B, which is actually very commonly used these days. If the patient has a severe penicillin allergy, we cannot use penicillin G. So we switch the main driver to vancomycin. The dose is 15 milligrams per kilogram IV every 12 hours.
Vancomycin? That is the big gun, no!
It is a very strong antibiotic, yes. But even with vancomycin, we still pair it with gentamicin to get that synergy.
But look closely at the duration in this alternative plan. I have highlighted it here in my notes.
Ah, yes. You've noticed it.
It says gentamicin for 4 weeks. In the first line with penicillin, it was only 2 weeks. Why the extension? That seems odd.
Very observant of you.
Yeah.
And it is a fantastic question. See, when you use vancomycin, the killing speed for certain organisms, like Enterococcus, for example, is a bit slower compared to penicillin. Or perhaps we're dealing with a more resistant organism from the beginning. To ensure we get that complete eradication, the guidelines recommend extending the synergistic component, the gentamicin, to 4 weeks.
But surely if 2 weeks of gentamicin is bad for the kidneys, 4 weeks is twice as dangerous.
It is. It is definitely risky. And that is why, if a patient is on this vancomycin gentamicin regimen for 4 weeks, the monitoring must be strict. We are checking creatinine levels daily or every other day. We're asking the patient, are your ears ringing? Do you feel dizzy? If the kidneys start to take a hit, we have to adjust the dose or stop. It is not a set it and forget it protocol. You have to be on your toes.
Right. Now, let's shift gears to scenario B. This sounds like a nightmare scenario. Uncomplicated prosthetic valve. This is someone who has already had heart surgery, correct?
Yes. They have a mechanical valve, the ones that go click, 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 or a tissue valve replacement. And now, unfortunately, that artificial part is infected. This is significantly harder to treat than a native valve.
Why is that? Is the bacteria different? More aggressive?
The bacteria might be the same, staph, strep, enterococcus, but their behavior is completely different. Bacteria absolutely love foreign materials, plastic, metal, their material, you name it. They latch onto it and secrete a very thick, slimy matrix called a biofilm. It is much, much thicker than on a native valve. It is like a shield.
So antibiotics can't get through.
They struggle to penetrate it. And the body's own white blood cells, they cannot clean the surface of a piece of metal the way they can clean living tissue. So the strategy changes. We have to hit harder and for longer.
Much harder.
Much harder. Look at the first line for prosthetic valve. We do not mess around with penicillin here initially. We go straight to vancomycin, 15 millikilogram IV every 12 hours. But look at the duration.
6 weeks.
6 full weeks. You cannot cut corners here. If you treat for 4 weeks and stop, chances are a few bacteria are hiding deep in that biofilm on the metal ring. They will wake up and the infection returns. And let me tell you, a second surgery to replace an infected replacement valve, the mortality risk is huge. So we commit to the 6 weeks of IV therapy.
And we still add the gentamicin. for that initial pick.
Yes, gentamicin 1 milligram every 8 hours, but again, usually limited to the first 2 weeks just to clear the bloodstream, the bacteremia.
There is also an alternative listed here involving a drug called daptomycin. I have heard of this one. It is quite new, isn't it?
Relatively new, yes. And daptomycin is a fascinating drug. It is a cyclic lipopeptide. The way it works is almost violent. It essentially inserts itself into the bacterial cell membrane and punches a hole in it.
It punches a hole.
Literally. Yeah. The cell leaks its contents, potassium flows out, and the cell just dies.
Yeah.
It's very bactericidal. It kills fast.
It sounds violent, but very effective.
It is effective, yes. The dose is 10 millikilograms every 24 hours. We use this if the patient cannot tolerate vancomycin or the vancomycin is not working, or if the minimum inhibitory concentration, the MIC for vancomycin, is creeping up. It is expensive, very expensive compared to vancomycin, but for a prosthetic valve, you have to do the needful to save the patient.
Do the needful. I think in this case, the needful is extremely expensive and intensive.
Indeed. But what is the cost of a life?
True. Now, let's look at scenario C. Complicated. Severe sepsis. This is the patient who is crashing.
This is the patient in the ICU. They are hypotensive, their blood pressure is dangerously low, they are confused, their organs are shutting down, kidneys failing, liver enzymes going up. This is septic shock. Here, empirical therapy is not just about guessing, it is about covering every single possibility, because if you miss, the patient dies within hours.
The combo here sounds like the nuclear option. Vancomycin plus meropenem.
Exactly. And let's break that down logic by logic. Vancomycin covers the gram-positive bacteria, Staphylococcus aureus, MRSA, Streptococcus. That is your standard valve infection. But why meropenem?
I was just going to ask. Meropenem is a heavy hitter. I've heard of it used for very serious infections.
Meropenem is a carbapenem. It has an incredibly broad spectrum. It covers gram-negatives like E. coli, Klebsiella, and anaerobes. In severe sepsis, you cannot be sure the infection is only from the heart. Or perhaps it is a rare gram-negative endocarditis, which is very, very aggressive. You simply cannot take that chance. So you use meropenem 1 gram IV every 8 hours to wipe out the gram-negatives and vancomycin to wipe out the gram-positives. You cover the entire map.
It is the kitchen sink approach. Everything but the kitchen sink.
It is. You stabilize the patient first. Once the cultures come back, say 3 days later, and it turns out to be just a simple strep, you stop the meropenem immediately and switch to penicillin. You de-escalate. That is good antibiotic stewardship, but up front, you go big.
And there's an alternative listed here too, daptomycin plus meropenem.
Same logic, exactly. Daptomycin 10 millikilo OD. Once daily covers the gram-positives, meropenem covers the rest. It's just using a different hammer for the gram-positives.
Before we leave endocarditis, I want to touch on the diagnostic nuances section, because all this treatment relies on knowing you actually have endocarditis. The text mentions echocardiography.
It's mandatory. It says should be performed in all suspected cases. You need to see the vegetation, you need to see if the valve is leaking, if there's regurgitation, and echo gives you that visual confirmation.
But what if the echo is fuzzy or inconclusive?
That happens often. Maybe the patient has COPD and has a lot of air in the chest, or is obese, or has a prosthetic valve that casts a shadow on the ultrasound. In those cases, the guidelines suggest PT-CT scans.
PET scans. I usually associate those with cancer hunting.
It is the same principle, actually. You inject a radioactive sugar tracer. Bacteria are very metabolically active. They eat sugar like crazy. So the infected area on the valve, or around the valve ring, lights up on the scan. It is incredibly useful for finding hidden infections, especially around prosthetic valves where the echo struggles to see.
Now here is the curveball expert. We have spent 15 minutes saying, start empirical therapy now, don't delay. But right here on page 15, there is a note. Ideally, clinicians should wait for blood cultures if the patient is stable.
Yes, and this is where the art of medicine comes in. This is where the experienced doctor earns their salary.
It feels contradictory, though, doesn't it?
It feels that way, but it's pure logic. If a patient is stable, meaning they are sitting up, talking, their BP is fine, they just have a fever and a murmur, you have a bit of time. If you give antibiotics before you take the blood culture, you risk sterilizing the blood. The culture comes back negative.
Oh, right.
Now you have a patient with a valve infection, but you do not know which bug it is. You don't know if it is sensitive to penicillin or if it is a superbug. You are flying blind for the next 6 weeks of therapy.
So by treating too early in a stable patient, you actually sabotage your own long-term success.
Exactly. You ruin the diagnostic yield.
Right.
So in a stable patient, you admit them, you take 3 sets of blood cultures spaced out over a few hours, and you wait. You watch them like a hawk, check their vitals every hour, but you wait. Once you have the culture securing the diagnosis, then you start. Targeted therapy is always superior to empirical carpet bombing.
But if they are unstable?
If they are unstable, you shoot first and ask questions later. You draw the blood and immediately inject the vancomycin and meropenem. You cannot risk the patient dying while you wait for a lab tech to process a sample.
It is a tough call to make in the casualty ward at 2 a.m. Is he stable enough to wait?
That is the million-dollar question. That is why experience matters so much.
Okay, let us shift gears completely. We are leaving the bacterial battlefield and moving to section 3, acute myocarditis. And this was the biggest shock for me when I read the notes.
The inflammatory paradox, yes.
The guidelines explicitly state no empirical antibiotics are required for uncomplicated or complicated myocarditis.
I want to repeat that for everyone listening, especially the medical students out there. No, empirical antibiotics.
But why? Myocarditis is inflammation of the heart muscle. We associate inflammation with infection, so why no drugs?
Because of the etiology, the cause. Acute myocarditis is almost always viral. Coxsackie B virus, adenovirus, parvovirus B19, or, more recently, post-COVID inflammation. Antibiotics kill bacteria. They're completely useless against viruses.
So if you give antibiotics, you're just causing harm.
You are exposing the patient to risks, allergies, kidney damage, C. diff diarrhea, promoting antibiotic resistance for absolutely zero benefit. It is core medicine. The guidelines are strict. Antibiotics are only initiated if a bacterial cause is confirmed, which is actually quite rare.
So if we aren't killing the bug, what are we doing? The protocol says rest and supportive care. It sounds a bit old-fashioned. Just get some rest, Beta.
It sounds simple, but rest here is a potent medical prescription. Think about it. If you have a broken leg, you put a cast on it so the bone doesn't move. You rest the bone. You cannot put a cast on the heart. It has to beat to keep you alive. But if the heart muscle is inflamed and swollen, every beat is trauma. Every time you run or walk fast or get stressed, the heart rate goes up and the damage increases. So rest means strict limitation of physical activity. We want the heart rate low. We want to reduce the workload of the heart so the muscle can heal itself.
And for severe cases, if the heart is really struggling to pump,
then we escalate to supportive care. We might use immunomodulators, specifically steroids, corticosteroids.
To calm the immune system down, to stop it from attacking the heart.
Exactly. Myocarditis is often immune-mediated. The virus triggers the immune system, and then the immune system goes a bit crazy and starts damaging the heart cells. The steroids tell the immune system to calm down.
And if the heart starts to fail, if the pump function is weak,
then we open the heart failure toolkit. We use diuretics, water pills like Lasix to get the fluid off the lungs. We use beta blockers to slow the heart rate and reduce oxygen demand. We use ACE inhibitors to lower the blood pressure so the heart doesn't have to push against so much resistance. And importantly, anticoagulants.
Blood thinners. Why is that necessary?
Because when the heart is inflamed and not pumping well, the blood tends to stagnate in the chambers. It just sits there. And stagnant blood clots. You do not want a young patient with myocarditis to suddenly have a massive stroke because of a blood clot shooting up to the brain. So we thin the blood to prevent that.
So the strategy is totally different. In endocarditis, we are attacking the invader, the bacteria. In myocarditis, we are supporting the host, the heart, and just waiting for the storm to pass.
Beautifully summarized. That is the fundamental difference.
Let's move to section 4, pericarditis. This is the inflammation of the sac surrounding the heart.
The pericardium, yes.
And looking at the guidelines, the rule seems to be exactly the same as myocarditis, no?
Almost identical regarding antibiotics. No empirical antibiotics recommended. Again, the vast majority of pericarditis cases are viral or idiopathic, meaning we don't know the cause, but it's likely viral or inflammatory. It is not bacterial. So no antibiotics unless you have laboratory proof.
But pericarditis has a specific complication that sounds terrifying. Tamponade.
Cardiac tamponade. It's a medical emergency. If you see this, everyone starts running.
Can you explain what happens there? What is actually going on?
Imagine the heart is inside a balloon. That is the pericardium. Normally, there's a tiny bit of fluid there to lubricate, but in pericarditis, the inflamed layers start weeping fluid. The balloon starts to fill up. Now, the pericardium is tough. It doesn't stretch very quickly. So as the fluid builds up, the pressure inside the sac rises. It starts to squeeze the heart.
Like a snake constricting its prey.
Exactly. And the heart is a pump. To pump blood out, it first has to fill with blood. If the pressure outside is crushing it, the heart chambers cannot expand. They cannot fill. If they don't fill, they don't pump. The blood pressure crashes, and the patient goes into shock.
So what is the fix? The text mentions pericardiocentesis.
That is the fancy word for sticking a needle in it. You insert a long needle through the chest wall, right under the sternum, into the pericardial sac, and you drain the fluid.
It sounds incredibly dramatic.
It is immediate relief. It is like letting the air out of a tire that is overinflated. The heart pops open, it fills with blood, the blood pressure shoots up, and the patient is saved instantly. It is also diagnostic. You send that fluid to the lab to see if it is TB or cancer or just viral.
And for the medical management, apart from sticking a big needle in,
We use anti-inflammatories. NSAIs like ibuprofen or indomethacin are the mainstay, high doses. And colchicine, an old drug used for gout, is very, very effective for pericarditis.
what about steroids here? We use them in myocarditis. Are they used here as well?
The guidelines say on a case-to-case basis, we are a bit cautious with steroids in pericarditis. While they reduce pain very quickly, they're associated with a higher rate of recurrence. If you use steroids, the pericarditis is more likely to come back later. So we try to stick to NSAIs and colchicine first.
Okay, so no antibiotics unless proven. Focus on the fluid and the inflammation.
Correct. That's the mantra.
Now let's move to the final section. Section 5, rheumatic fever. This feels like something from a Charles Dickens novel, but is still very relevant in many parts of the world, including here in India.
Oh, it is massively relevant. Rheumatic heart disease is still a leading cause of heart valve failure in developing nations. And it all starts with a simple sore throat.
A sore throat? How does a sore throat lead to heart failure?
Group A beta hemolytic Streptococcus, strep throat. If a child gets a strep throat and it is not treated properly, the body's immune system creates antibodies to fight the bacteria. But, and this is the tragedy of it, the bacteria look very similar to the molecular structure of the heart valves. It is called molecular mimicry.
So the antibodies get confused.
The antibodies attack the bacteria, but they also get confused and attack the heart valves, the joints, the brain. And the damage to the valves is permanent. They get scarred and stiff.
The guidelines here seem to have a two-pronged mission: elimination and prophylaxis. Let's start with elimination.
Right. You have a child presenting with acute rheumatic fever joint pain, fever, maybe heart involvement. First, you must eradicate any lingering strep bacteria from the throat to stop the immune stimulation.
The uncomplicated treatment listed is, well, it is the classic.
Option A, penicillin G benzathine. A single intramuscular or IM injection.
The famous shot.
The painful shot. It is a thick, milky suspension. It hurts, I won't lie. But it is miraculous. One shot provides adequate levels of penicillin for weeks. It clears the carrier state.
And if the parents or the patient refuse the shot, or it's not available,
Option B is penicillin V by mouth, 500 milligrams every 8 hours for 10 days.
10 full days. That requires a lot of discipline.
It does. And if you stop at day 5 because the child feels better, you fail to eradicate the bug completely. That is why the shot is preferred. Compliance is 100% once you give it because the doctor gives it.
And for penicillin allergy?
We use azithromycin. 500 milligrams orally, once daily for 5 days. It is simpler, but again, penicillin is the gold standard.
Now this is the part that really blows my mind. Secondary prophylaxis. The long game.
This is the most critical part of the guidelines, the most important intervention we have. If a patient has had rheumatic fever once, their immune system is primed. If they catch strep throat again, even a mild one, the immune system will launch a massive, almost nuclear attack on the heart valves. The damage will be 10 times worse. We call it recurrent rheumatic fever.
So we have to prevent them from ever getting strep throat again. For how long?
For years, sometimes until age 21, sometimes until age 40, sometimes for life if the valves are badly damaged.
For life. And the regimen, what is it?
The regimen is benzathine penicillin G injections every 3 weeks.
Every 3 weeks. For years and years.
Every 21 days. You have to come to the clinic, get that deep IM injection, and go home, rain or shine, for maybe 20 years.
That is a huge burden on a patient. I can't even imagine.
It is. Imagine being a teenager and having to go for a painful shot every 3 weeks. It hurts to sit down afterwards. But the alternative, mitral stenosis. The valve becomes tight like a fish mouth. You cannot breathe. You eventually need a valve replacement surgery, which requires blood thinners for life. Compared to that, the shot is a small price. But compliance is the biggest challenge we face.
Are there oral options for this prophylaxis? A daily pill, maybe?
Yes, the guidelines do mention oral penicillin V, 250 milligrams twice daily, or oral erythromycin. You can take a pill every day.
That sounds much easier.
Theoretically, yes, but practically. Can you remember to take a pill twice a day, every single day for 10 years without fail? Most people forget. They miss doses. If you miss doses and catch strep, you are in big trouble. The injection works because we know it is in the body. It is directly observed therapy.
I see. The reliability is just not the same. And finally, for rheumatic fever, there is supportive care for the acute phase. What does that entail?
This is for the arthritis, the joint pain. Rheumatic joints are incredibly painful. The child cannot even bear the weight of a bedsheet on their legs.
And the drug of choice for that?
Good old aspirin.
Right.
High-dose aspirin. The response is almost magical. You give the aspirin, and within 24 hours, the pain vanishes. In fact, we used to say, if the aspirin doesn't fix the joint pain, it isn't rheumatic fever.
Interesting. So it acts as a diagnostic test almost.
In a way, yes.
Yeah.
We also use steroids for severe heart inflammation carditis, but aspirin is the mainstay for the joints.
So we have covered the 4 big syndromes. I want to try and summarize this to make sure I have got the deep dive takeaways right.
Please go ahead. Let's see.
Okay. Number 1, infective endocarditis. The strategy, hit hard, hit fast. The concept, synergism, you need the combo. The weapons, penicillin or ampicillin plus gentamicin for native valves, vancomycin plus gentamicin for prosthetic valves, and the nuclear option, meropenem for sepsis. And the caution, watch the kidneys with gentamicin. And if the patient is stable, wait for cultures.
Perfect. You have captured the nuance of stable versus unstable perfectly. That's the key.
Number 2 and 3, myocarditis and pericarditis. The strategy, hold your fire, don't shoot. The concept, it is likely viral, not bacterial. The weapons, rest, steroids maybe, and NSAIDs. The caution, no empirical antibiotics, and watch out for tamponade, the fluid in the sac.
Spot on. The discipline to not prescribe is key here.
And finally, number 4, rheumatic fever. The strategy, eliminate and protect. The weapons, penicillin, benzene. The long game, the 3-weekly shot for years to prevent recurrence.
You have nailed it. That is the essence of pages 15 to 18.
It really makes you appreciate the complexity of what cardiologists and physicians do. It is not just heart problem equals pill. It is a constant decision tree. Is it bacterial? Is it viral? Is it the immune system? Is the patient stable?
It is. And it brings me to that so what for our listeners.
Yeah.
Why does all this matter to you? It matters because knowledge is empowerment. If your relative is admitted with pericarditis, maybe chest pain after a viral flu, and you see the resident doctor starting strong IV antibiotics, you can ask the question. You say, doctor, I thought pericarditis was usually viral. Is there a reason we're suspecting bacteria?
Right. You aren't challenging them aggressively, but you are asking informed questions. You become an advocate for your family member.
Exactly. Or if you have a family member with a prosthetic valve who gets a fever, you will know. This is dangerous. We cannot wait. We need to go to the hospital immediately because if it is endocarditis, that biofilm forms fast.
And also, for the rheumatic fever patients or parents of those patients, understanding why that injection is needed every 3 weeks. It is not a punishment. It is an insurance policy for the heart valves.
Precisely. It changes the mindset from why are you hurting me to we are protecting my future.
Before we wrap up, I have one final thought that has been buzzing in my head. We talked about the stable versus unstable call in the ER for endocarditis. The guidelines say, wait if stable, treat if unstable. But stability is a spectrum, isn't it? A patient can be stable at 10:00 a.m. and crashing at 10:15 a.m.
That is the nightmare scenario.
It highlights that medicine is as much about timing and risk assessment as it is about chemistry. How do doctors make that split-second call? It is not just data on a screen. It must be intuition. It must be experience. It is watching the patient's eyes. No.
That is the art part of the art and science of medicine.
Yeah.
The guidelines give you the map. They tell you the route. But you, the doctor, are driving the car. And sometimes it is raining or there is a landslide and you have to take a call. You have to react. No guideline can replace the clinical eye.
Well, on that note, we will leave you to ponder the incredible balancing act that happens in our hospitals every single day. Thank you for listening to this deep dive into cardiovascular protocols. We hope you learned something valuable.
Thank you. Keep your hearts healthy.
Until next time.